Welcome to today's lecture on anaphylaxis, a topic that goes deep into the fascinating world of allergic responses and their potential life-threatening consequences. In this lecture, we will explore the definition and pathophysiology of anaphylaxis, shedding light on the intricate mechanisms that underlie this severe and rapid onset allergic reaction. An allergic response, also known as hypersensitivity, is essentially an exaggerated immune reaction to a substance that under normal circumstances should not pose a threat to the body. The immune system is overreacting to an otherwise harmless invader. This overreaction occurs when the immune system recognizes the substance known as an allergen as a foreign intruder. What's interesting is that the immune response is disproportionately intense compared to the actual threat posed by the allergen. This hypersensitivity reaction is often characterized by the production of a specific type of an antibody called immunoglobulin E, or IgE for short. Now let's zoom in on anaphylaxis, a term that strikes fear into the heart of many due to its severity and rapid onset. Anaphylaxis is a heightened form of allergic reaction, one that can progress very quickly and have life-threatening consequences. To understand the pathophysiology of anaphylaxis, we need to understand the complex interplay of immune cells, antibodies, and chemical mediators that direct this dramatic response. At the heart of anaphylaxis lies a specific type of immune reaction known as type 1 hypersensitivity reaction. This reaction is mediated by IgE antibodies, the same antibodies responsible for the allergic response. When a person with a predisposition to allergic encounters an allergen, their immune system goes into overdrive. The IgE antibodies bind to the allergen, setting off a cascade of events that leads to the release of various chemical mediators, including histamine. These chemical mediators are like the directors of anaphylaxis. They cause blood vessels to dilate, resulting in the drop in the blood pressure. They also can make blood vessels more permeable, leading to the leakage of fluids into the tissue and, in severe cases, causing swelling and hives. Additionally, these mediators can trigger bronchoconstriction, particularly a dangerous aspect of anaphylaxis. Now that we have covered the basis of the immune response and the role of IgE antibodies, let's dive deeper into what happens in the body before anaphylaxis can occur. Before the dramatic onset of anaphylaxis, a crucial process called sensitization must take place. This process begins with the initial exposure to an allergen, which is essentially the trigger for all that follows. When the body encounters the allergen for the first time, it sets in motion a series of events that will lead to the production of specific type of antibody called IgE. These IgE antibodies are designed to recognize and remember the allergen they encountered. They bind to receptors on two types of immune cells, mast cells and basophils, which are strategically scattered throughout various tissues in the body. Now let's fast forward to the second encounter with the same allergen. This is where the real action begins. The allergen molecules, upon re-entry into the body, binds to the IgE antibodies already stationed on the surface of mast cells and basophils. It acts like lock and key mechanism, where the allergen being the key and IgE antibody serving as the lock. This binding event, also known as cross-linking, is the trigger that sets off a rapid and a powerful response by these immune cells. When the cross-linking occurs, it's like flipping a switch and unleashing a cascade of events. Mast cells and basophils, once activated, release an arsenal of chemical mediators that were stored within their granules. The most notorious of these mediators is histamine, but there are others like tryptase and tumor necrosis factor in the mix. Now let's talk about the consequences of this chemical release. The effects are widespread and can impact various systems throughout the body. Here is a quick rundown: bronchospasm, tissue swelling and angioedema, fluid shift, vasodilation, mucosal and skin symptoms. Now that we have covered the mechanisms behind this severe allergic reaction, let's turn our attention to how we diagnose anaphylaxis. Anaphylaxis can be triggered by a wide range of allergens, from food like nuts, shellfish, to medications such as penicillins and cephalosporins, and even insect stings. Interestingly, IV contrast, often used in medical imaging, does not follow the IgE mediated mechanism seen in typical allergies, but its clinical presentation can mimic anaphylaxis due to the rapid onset of symptoms and involvement of similar chemical mediators. So how do we diagnose anaphylaxis? There are three sets of criteria that, if any one is met, can confirm the diagnosis. The first set of criteria revolves around skin and mucosal involvement. This includes symptoms like rash, flushing, and hives. These are often indicative of an allergic reaction involving the release of histamine and vasodilation. Alongside these skin symptoms, anaphylaxis may manifest with respiratory symptoms such as wheezing, stridor, dyspnea, and hypoxemia. These symptoms are commonly caused by bronchoconstriction and airway swelling. Additionally, anaphylaxis can lead to hypotension and hypoperfusion. Symptoms such as syncope and incontinence can result from decreased blood flow due to vasodilation and fluid shifts caused by anaphylactic reaction. Patient may also present with gastrointestinal symptoms like nausea, vomiting, abdominal pain, and diarrhea. The second set of criteria. If a person experiences the symptom described above after exposure to a known allergen, this is a strong indicator of anaphylaxis. This known allergen could be something they have encountered before and had an allergic reaction to. The third diagnostic criteria focuses on a known allergen that has triggered anaphylaxis in the past. If a person with a history of anaphylaxis encounters that specific allergen again and experiences hypotension, this is considered a clear sign of anaphylaxis. Now let's understand the critical strategies for managing this potentially life-threatening condition. When it comes to anaphylaxis, there is a star player that takes center stage: epinephrine. Epinephrine is the cornerstone of anaphylaxis treatment. How does it work? Let's explore its mechanism of action and recommended dosing. First off, 0.5 milligram of epinephrine is typically administered intramuscularly into the lateral thigh. If necessary, this dose can be repeated every 5 to 15 minutes. But what if a patient does not respond well to intramuscular epinephrine? Well, there is a plan B. An intravenous infusion of epinephrine can be initiated. Now let's break down the superhero abilities of the epinephrine: bronchodilation, vasoconstriction, inhibition of histamine release, and increased cardiac output. In the case of anaphylaxis, it's not just about administering epinephrine. There are other key components to consider when ensuring the patient's well-being. Airway compromise can be a significant concern in anaphylaxis. This can happen due to laryngeal edema or bronchoconstriction. Ensuring adequate oxygenation is paramount. High flow oxygen may be necessary to maintain oxygen level and support the patient's breathing. In case of severe laryngeal edema causing the airway obstruction, more advanced airway management techniques may be required. This can include procedures like intubation and, in extreme cases, even cricothyroidotomy. To address bronchoconstriction, beta-2 agonist can be incredibly helpful. These medications relax bronchial smooth muscles, alleviating bronchospasm and making it easier for the patient to breathe. Anaphylaxis can also lead to significant fluid shift and hypovolemia. To address this, administering crystalloid is essential to restore intravascular volume. Antihistamines are another tool in the anaphylaxis management toolkit. They can help alleviate symptoms like hives and itching by blocking the effect of histamine. Diphenhydramine is a common choice for intravenous or intramuscular administration with a recommended dose of 50 mg. However, it is important to understand that antihistaminics do not have significant impact on the airway or hemodynamics. Corticosteroids like methylprednisolone are administered to help reduce inflammation and prevent late phase reactions. Corticosteroids have a delayed onset of action and are not considered the primary treatment for acute anaphylaxis, but they can be valuable in preventing relapses and late phase reactions. Crucial note of caution: avoid using unopposed alpha adrenergic vasopressors. These medications can exacerbate vasospasm and decrease perfusion in the certain areas, potentially worsening the anaphylactic response. If vasopressors are needed to manage hypotension, they should be used cautiously and balanced between their alpha and beta effects. Now we are shifting our focus to the disposition of the patient who experienced these severe allergic reactions. What happens after the initial management, and how do we determine if a patient can be discharged or they require further observation and treatment? Let's delve into this critical aspect of anaphylaxis management. Disposition, in medical terms, refer to the decision regarding what to do with the patient after their initial treatment for an anaphylactic reaction. It's a pivotal moment in ensuring the patient's safety and well-being. Now let's consider different scenarios. If the anaphylactic reaction is limited to mild symptoms such as hives or mild bronchospasm, the patient may be considered for observation in the emergency department for a minimum of 6 hours. During this observation period, medical staff will closely monitor the patient's condition and their response to the treatment. It's like keeping a watchful eye to make sure things are on the right track. If there are no signs of worsening and the patient's symptoms are well controlled, they may be considered for discharge after this observation period. On the other hand, if a patient experiences more significant symptoms such as respiratory compromise, hypotension, or severe angioedema, the usual course of action is hospital admission. This allows for continuous monitoring of vital signs, administration of medications, and prompt intervention if there is any deterioration. It's a safety net to ensure that the patient receives the necessary care and attention. Now here is an important twist to consider: biphasic reactions. So what exactly is a biphasic reaction? Imagine this. After an initial improvement following an anaphylactic reaction, there is a sudden recurrence of symptoms. Yes, you heard that right. A second wave of symptoms can roll in after the first one subsides. And here is the real kicker: it can happen even without further exposure to the antigen. It's a medical mystery, and while we do not fully understand why it occurs, it is believed to be due to continued release of the inflammatory mediators and immune responses. Biphasic reactions are like the unexpected twist in the anaphylaxis plot, keeping us on our toes. This can occur within few hours up to 72 hours after the initial reaction, and with most happening within first 8 to 10 hours. And here's the part that keeps us guessing. The second phase can sometimes be as severe or even more severe than the initial reaction. But it can also manifest as milder symptoms. It's like a roller coaster ride with no clear pattern. Biphasic reactions add a layer of unpredictability to the management of anaphylaxis. Staying vigilant, being prepared, and following discharge instructions are essential steps to ensure the patient's safety and well-being during the critical post-reaction period. Let's move to our next segment, AIM IQ, the MCQ challenge. Here we review 5 multiple choice questions to evaluate your grasp of the concepts. So let's get started. Question 1. A 28-year-old female with a history of childhood asthma presents to the emergency department after ingesting shellfish at a family gathering. Within minutes, she develops urticarial eruptions, flushing, and severe respiratory distress. On examination, her blood pressure is 86 by 58 mmHg, pulse 140 beats per minute, respiratory rate of 32 per minute with audible wheezing. She is saturating 94% on room air. What is the most appropriate next best treatment? A. Administer intravenous corticosteroids. B. Initiate high flow oxygen via nasal catheter. C. Perform endotracheal intubation. D. Administer intramuscular epinephrine. E. Order a serum tryptase level measurement. Let's pause here while you answer the question. This patient's most appropriate initial treatment is administer intramuscular epinephrine. This patient is experiencing a severe allergic reaction, likely anaphylaxis, triggered by ingesting shellfish. Her symptoms include urticarial eruptions, flushing, respiratory distress, and wheezing with hypotension. These clinical signs indicate a systemic allergic response that can rapidly progress to a life-threatening situation. Epinephrine is the first-line treatment for anaphylaxis because it acts quickly to counteract the severe effects of the allergic reaction. It works by causing vasoconstriction, bronchodilation, and increased cardiac output. Administering it intramuscularly, usually in the thigh, ensures rapid absorption into the bloodstream. While corticosteroids may be used as a part of the treatment for anaphylaxis, they act more slowly and are not the primary treatment. Oxygen can help in anaphylaxis, primarily when respiratory distress occurs. The patient is currently saturating 94% on room air, so there is no urgent indication for supplemental oxygen support. Intubation may become necessary if the patient's airway becomes severely compromised. The patient is currently saturating 94% on the room air. While measuring serum tryptase levels can help confirm anaphylaxis, it is not the next best step. Question 2. A 50-year-old woman with a history of rheumatoid arthritis is admitted to the hospital for a joint flare and started on methotrexate. She develops generalized urticaria, hypotension and tachycardia shortly after receiving the first dose of the medication. She is saturating 94% on room air. Methotrexate has been discontinued. What is the most appropriate next best step in managing this patient's symptoms? A. Administer intravenous corticosteroids. B. Initiate high flow oxygen via nasal catheter. C. Order a serum tryptase level measurement. Or D. Administer crystalloids. Let's pause here while you answer the question. In this scenario, the most appropriate next best step in managing the patient's symptom is administer crystalloids. The patient is experiencing a hypersensitivity reaction shortly after receiving methotrexate, which has resulted in generalized urticaria, hypotension and tachycardia. And these clinical signs suggest the patient is in shock due to severe allergic reaction. Administering crystalloid fluids such as normal saline is crucial in shock cases to increase intravascular volume, improve blood pressure and enhance tissue perfusion. This helps to stabilize the patient condition and prevent further deterioration. While corticosteroids may be used to manage allergic reactions, addressing the patient's hypotension and shock is the immediate priority. Intravenous fluid should be administered before or alongside corticosteroids. Patient's oxygen saturation is already at 94%, which is acceptable. Oxygen supplementation is vital in cases of respiratory distress, but not the primary intervention for shock. Again, measuring serum tryptase level can help diagnose anaphylaxis. However, it is not an immediate step in managing the patient's acute symptoms. Question 3. A 29-year-old female presents to the clinic with recurrent episodes of anaphylaxis. She reports symptoms such as hives, flushing and abdominal cramping, which occurs randomly without any identifiable triggers. Physical examination and lab tests are unremarkable. Skin prick testing is negative. What is the most appropriate diagnostic test to further evaluate her condition? A. Repeat skin prick testing for common allergens in 3 months. B. Serum tryptase levels. C. Chest and cardiac imaging. D. Consultation with a psychiatrist to rule out conversion disorder. Now let's pause here while you answer the question. The most appropriate diagnostic test to further evaluate this patient's recurrent episodes of anaphylaxis is serum tryptase level. This patient presents with recurrent episode of anaphylaxis characterized by hives, wheezing and abdominal cramping. This case is challenging because these episodes occur randomly without any identifiable triggers, and initial physical examination and lab tests are unremarkable. Tryptase is an enzyme released by mast cells during degranulation, which occurs in anaphylaxis. Measuring serum tryptase level can provide valuable information. Elevated tryptase level during an acute episode and persistently elevated baseline levels can indicate an underlying mast cell disorder called mastocytosis. Mastocytosis is a condition with excessive mast cell proliferation, and it can cause spontaneous episodes of mast cell activation leading to anaphylaxis. Even though the skin prick test was negative, serum tryptase levels can help diagnose this condition. Since the initial skin prick testing was negative, repeating it may not provide any additional helpful information. The patient's presentation suggests a systemic condition not limited to a specific allergen. Imaging studies are typically not the initial diagnostic test for evaluating anaphylaxis, especially in the setting of a normal cardiac and respiratory exam. The patient's symptoms are more indicative of a systemic allergic reaction. While psychiatric evaluation may be considered in certain cases, it should not be the initial diagnostic test for recurrent anaphylaxis. Medical causes like mast cell disorders should be thoroughly evaluated first. Question number 4. A 28-year-old male with a known egg allergy accidentally ingested salad containing egg white at a party. He presents to the emergency department with generalized hives, dyspnea and stridor. Despite initial treatment with IV epinephrine, IV antihistamines and corticosteroids, his symptoms worsen and he develops polyphonic wheezing and stridor. What is the next step in the management? A. Administer IV magnesium sulfate. B. Initiate continuous albuterol nebulization. C. Administer IV diphenhydramine. Or D. Prepare for emergent intubation. Now let's pause here while you answer the question. In this clinical situation, the next step in management is to prepare for emergent intubation. The patient has a known egg allergy and is experiencing a severe allergic reaction with symptoms that include generalized hives, dyspnea, and stridor. Despite initial treatment with IV epinephrine, IV antihistamines, and corticosteroids, his symptoms have worsened and now he has polyphonic wheezing and stridor. The development of polyphonic wheezing and stridor is a sign of severe airway obstruction. When a patient with anaphylaxis does not respond to initial treatments and experiences worsening respiratory distress, it is essential to prepare for emergent intubation. Intubation is necessary to secure the airway, maintain oxygenation, and provide mechanical ventilation to prevent respiratory failure. While magnesium sulfate can be used in some cases of severe asthma exacerbation, it is not the primary intervention for anaphylaxis with stridor and worsening respiratory distress. Securing the airway is the immediate priority. Continuous albuterol nebulization may be considered in cases of severe bronchoconstriction, but it is an adjunct treatment when patient's condition has deteriorated to the point of stridor and polyphonic wheezing. Diphenhydramine is an antihistamine, but the immediate attention should be on managing the airway and providing the respiratory support. Question number 5. 65-year-old male with a history of coronary artery disease presents to the emergency department with chest pain and shortness of breath. He received a bee sting while gardening 30 minutes prior to the onset of symptoms. His vital signs are stable. ECG shows ST segment elevation in lead 2, lead 3 and AVF. What is the most appropriate intervention for this patient? A. Administer intravenous epinephrine. B. Initiate high-dose corticosteroids. C. Venom immunotherapy. D. Initiate antihistamines. Or E. Immediate percutaneous coronary intervention. Again, let's pause here while you answer the question. In this clinical scenario, the most appropriate intervention for this patient is, yes, immediate percutaneous coronary intervention. This patient has a history of coronary artery disease and is presenting to the emergency with chest pain, shortness of breath, and ST segment elevation on the EKG. These findings indicate an acute myocardial infarction, specifically involving the inferior wall of the heart, as evidenced by ST segment elevation in lead 2, 3 and AVF. The patient's symptom and ECG finding suggest a myocardial infarction, a life-threatening cardiac emergency. The most appropriate and time-sensitive intervention in this case is PCI. PCI involves using a catheter to open the blocked coronary artery, which can quickly restore blood flow to the heart muscle, minimizing cardiac damage and improve patient's chances of survival. While epinephrine treats anaphylaxis, the patient's vital signs are stable and his primary concern is acute myocardial infarction. The immediate focus should be on addressing the cardiac emergency. Epinephrine will increase the oxygen demand and may be detrimental in the setting of acute myocardial infarction. Corticosteroids are not indicated as the primary treatment for an acute myocardial infarction. The priority is to re-establish blood flow to the heart muscle achieved through PCI. While the patient did experience a bee sting, the current presentation is more consistent with a myocardial infarction. The urgent need is to address the heart-related symptoms. So there is no indication for venom immunotherapy for now. Antihistamines treat allergic reactions, such as those from bee stings. However, the patient's critical issue is his heart condition, and addressing that should take priority. With this thought, I will take your leave until we meet again. If you like this video, please like, share and subscribe to our channel. Read well, revise more, aim high.